And I would then like to start with the first question. Based on your opinion, how can digitalization improve the quality of primary care?
First of all, thank you so much for the invite. It's really nice to see a few familiar faces around and some new ones as well. So when people ask me about quality, I always feel that it helps thinking about what is quality, what kind of impacts are we looking at, and there's a framework that I really like. There's so many different quality frameworks, but there's one from the Institute of Medicine in the US that will break down quality in 6 domains: patient-centeredness, effectiveness, efficiency, timeliness, safety, and equity. And I wonder, when we talk about digital health that potentially can impact all these domains, it can maybe develop solutions that allow us to provide more patient-centered care. It can potentially help us to manage effectiveness and health outcomes a bit better. It can potentially allow us to reach out to groups that are living in remote areas. So my main reflection is it's a double-edged sword. Digital health can impact positively all these dimensions of quality, but at the same time, we need to be very mindful of the risk of having a detrimental and negative impact in all these domains of quality. So I guess the reflection for me is pretty much about which digital health solutions are ideally placed to tackle specific challenges and to improve quality. But again, being very mindful that we can only have a negative impact in those dimensions of quality when we try to implement the digital solutions. So these are just some very high-level thoughts, and I'm sure others will probably add more.
I mean, I'm happy to share a couple thoughts, Lauren. I mean, I think what's helpful, I mean, first, maybe we have to use our imagination, because the question is, are we talking about what could be improved tomorrow, or are we thinking about what are the possibilities? And so it's helpful, I think, to lay out the possibilities, because then we can look at what are the problems of getting there. And as Anna Louise already said, and what are the undesirable detours that might happen along the way. So what is the vision of a digitally enabled health system? Well, what's also happening is the development of low-cost diagnostic technologies. So people will increasingly have access to easy ways of measuring their temperature, their blood sugar, their blood pressure, EKG. You can think of how many increasingly are becoming possible. Whether they have access themselves or they input it and their provider or the pharmacy has access, but one way or another, there's access. Then we've all talked for years about evidence-based care, but of course that can be translated into easy treatment guidelines or algorithms. So they have access, either they or the provider has access to algorithms that can translate what is the problem into what is a useful solution. Then we have to remember, because a lot of the initial digital innovations were fine, but people couldn't get access to the medicines. So we know that with a lot of digital solutions, on the one hand, you have the digital, but it links to suppliers of drugs so that they could get treatment easily. Eventually, with artificial intelligence, it'll be possible to have more tailored solutions for different problems in different patients. And with an electronic health record, it should be easy to go for referral, to come back, etc. So the vision isn't just that it's digitally enabled, but there's new diagnostic technologies and new ways of managing care. Now, I'm sure we'll come to all the problems of getting from where we are to where that might be. But I think it's useful to have that vision to see where we're heading, even if it's going to be quite difficult getting there.
I just thought I'd maybe, come around the loop over there, just to add to what Anna and Gerry were saying. To me, digital innovation is something that is already happening. It's not something about the future. It's very much part of the here and now. And to me, I would agree with Anna about what really defines quality, or what one means by quality, because in many of the countries where digital innovations are impacting primary care, the standards of quality seem to be an arc, really. There is no real definition of what we mean by high quality care or low quality care. Where I do see a lot of this digital disruption happening is in that interface between access, cost, and quality. And that's where these newer models of care are really beginning to make an impact. They are improving access by particularly accessing populations that otherwise may not have access to primary care. Whether it's of good quality or not is highly debatable. And they are also accessing populations who are hitherto unable to afford good quality primary care. Again, it's the quality debate. It really depends. So to me, digital technology in primary care is really here to stay. It's more a question of now beginning to integrate it more with existing primary healthcare systems, where broader frameworks around what defines quality need to be thought about more clearly, particularly when you're engaging digital actors. And of course, one has to look at the future as well, and many countries are beginning to do so. But to me, working on the field and on the ground, particularly with the plethora of digital actors in the non-state sector that have not only begun to change the way people are accessing primary healthcare, but are kind of redefining the way they are beginning to look at healthcare from both a digital device perspective, that is, individual wearable devices, as well as looking at how some of these technologies are being embedded in primary care clinics and being used by doctors and by public health centers, as well as private clinics. So it's really the digital landscape for primary healthcare, I think, is extremely ripe. And now it's more a question of larger questions around integration and frameworks and larger digital public architectures that will embed these, that will, I think, define future conversations.
Yeah, thank you a lot for all your great responses to this question. And now I would like to come to the topic, which is also part of the Global Forum, which is universal health coverage. In which way do you see digitalization being able to improve access and to enable universal health coverage? And in which way might it not be?
Yes. So I really wanted to echo what Priya said about the plethora of key stakeholders, but also digital intervention that we have at the moment. And I wonder if we should, so when we started having these discussions about digital health and how it can impact services, we were quite general, but the system has become so complex that I feel very anxious. And again, that's not a criticism, but when someone asked me, what do you think about digital health implementation? Or even what do you think about AI potential in primary care? Or what do you think about virtual consultations in primary care? Because these big buckets are so broad, it's completely different. We know the challenges from a patient perspective are different from a telephone consultation to a video consultation, let it alone thinking about digital health more broadly. So I just want to raise this because I think it's a challenge for us discussing these kind of things at a quite high level. And eventually at some point we need to focus in specific examples of specific digital solutions and how they fill specific gaps. I know it's a tricky exercise. So answering to your question, Florian, one aspect that I think about quite often, when we talk about universal health coverage, we talk quite often about task sharing, task shifting. How do we actually ensure that with the limited resources that we have, we are able to provide care for all? And we have discussed in the past how we share these with different health professionals, with nurses, midwives, allied health professionals. So from my perspective, digital health does emerge as a different or a new angle for task sharing, because some of the tasks that we do in partnership with patients, self-management, remote monitoring, can be actually leveraged using digital technologies. So I would see that as an obvious route to improve universal health coverage. The other thing, it's telemedicine, which we have all heard about too much in the last years, I'm sure. And I always try to make this exercise to remind myself what are the roots of telemedicine. So telemedicine originally was not developed for high-income countries or to provide more convenient care. Telemedicine in its roots decades ago was developed to reach out to populations in remote areas that didn't have medical expertise or specialty expertise. So I think that original vision of telemedicine to overcome difficulties of access in underserved and in remote areas is something that we should probably keep in mind moving forward. And that's another route to achieve universal health coverage. So I just leave these two maybe just to give time for others as well.
I've been involved in health systems for a long time. And one of the problems people have consistently talked about is we all know that there's a growing burden of non-communicable diseases. We all know that there's very simple measures can be taken to control blood pressure. We know there are very simple measures that can be taken to deal with problems of diabetes. But it's very difficult to do. And it's particularly, in a way, from what Ana Luisa said, it's very difficult in many countries to have full coverage for everyone with hypertension by a GP. It's unlikely. So we can easily see that for these kind of chronic problems, one can have new thinking, and you can call it task shifting. It's not very difficult to find a way for an individual or a not highly trained provider. It could be a community health worker. In a number of countries, informal drug sellers are very important. To take blood pressure frequently, monitor and take action where necessary, not difficult to monitor blood sugar. So we could easily see the possibility of quite quickly expanding coverage for chronic diseases using digital health. But, and I guess here is the but, healthcare, including for chronic diseases, isn't simply a question of information. It's not simply a question of taking blood pressure. It's not simply a question of measuring blood sugar, but there is a value to face-to-face interactions, and there is the risk that these digital solutions can simply allow governments and public health services to withdraw. So I think we need to find a new balance between face-to-face consultations that help people deal with health problems, but increasing capacity for individuals or people with moderate levels of training to support management of health problems. I think that's a big challenge. It's not simply a technological challenge. It's a conceptual challenge. It's a rethinking of who is responsible for what, and it's an organizational challenge of how do we make the best use of these possibilities of digital health.
Thanks, Gerry and Anna. And it's hard to really build on what they've said, because I completely agree with both of them. But if I were to answer this question in a very short way, how can digitalization improve access to care to enable UHC? I would say it can. It is doing so, and it is doing so as a facilitator. And again, this is highly contextual. It's contextual because the world in which current health systems operate at different levels. There are countries where digitalization will be used to make up for the lack of human presence. And that could be in far more advanced health systems that we see today that are often plagued by long waiting times, particularly in the primary care space. And in some ways, it will enable much greater access and much deeper access to populations that may otherwise not have that kind of access to primary care. To me, again, it is about the kind of players that are there in the digital health market today and how those different players are eventually aggregated into a larger system of what creates a primary healthcare continuum. Let me give you an example. Particularly in emerging, low middle income country settings, and I can give you the example of India, where there's actually been an explosion of digital healthcare providers in the primary care space alone. Leave alone more advanced technologies looking at orthopedic surgeries and hospital care and integrating those systems. But simply in primary care, there have been a plethora of digital providers who are essentially from outside of the existing public healthcare system. Now, how you choose to integrate them will depend a lot on the kind of integrated systems a country is evolving for universal health coverage. And digital is definitely going to play a huge role in facilitating some of that. It can definitely not replace a physician or a one-on-one consultation with a patient, but in terms of preventive screening, in terms of preventive diagnosis, or in the case of surveillance. I mean, in countries where there was very poor infectious disease surveillance, digital technologies have played a huge role during and after COVID in shoring up some of those surveillance capacity. So at the end of the day, I think it's also about how different countries are looking at how digital can make a change or make an effect in their systems. India, for example, has come up with something called the National Digital Health Blueprint, which is a federated architecture with a unique health ID that actually aims to connect community health providers. It aims to connect, the hospital system. It aims to connect some of the HMIS platforms, and it aims to connect, the human resource and health platforms. So it is actually developing an architecture that invariably will begin to connect some of these digital providers into a larger primary healthcare continuum. That is where I see digital or digitalization eventually impacting UHC. Because at the end of the day, right now, where many of the digital providers stand, there's very little scale. There's depth, but no scale. And for UHC, you need to have that scale and care continuum to really make an impact.
Yeah, thank you. It happens that this is an issue that is being discussed quite a lot. I'm not a physician, I have to tell you. I come from the community, from the civil society, and I'm working together with the G20 in the part of the C20 this year in Brazil. And one of the health priorities that the G20 has this year in Brazil is exactly digital health. And understanding that this is for the expansion of telehealth, integration and analysis of data from national health systems, which means that this is an issue that is being discussed quite a lot in all countries, because it's understood that it will bring information sharing and the promotion of digital tools concerning health workforces and resources and investments in low and middle income countries towards UHC. I think that it is important to follow this line, because especially with AE at this time, this may make a bigger change in health system and health care for everybody. Thank you.
I mean, my response would be that it's very good that the G20 is considering it, because I think what we're going to come to is, without government guidance, without some changes in regulation, there are risks as well as benefits. And I think it's good that governments are starting to discuss this and to really start thinking about what kind of agreements are going to be needed internationally to make this really beneficial.
And just to add to Gerry, one of the biggest debates that are happening at the G20 level, and this began in Bali and then in New Delhi and now carrying over to Brazil, is the development of countries increasingly thinking about what they call global digital architectures or global integrated digital health solutions. This is going to be the debate which will probably dominate the future at the macro level, because as digital tools and technologies get increasingly prevalent, I think country health systems will need to play catch up to see how they could be better integrated into existing ways in which they could actually fit into certain health system tiers and levels. And secondly, I think, which is the larger and more important question, how do you regulate them? Because a lot of them are from outside of the health sector. So things like who will own integrated data platforms? How do you deal with certain, artificial intelligence enabled tools and technologies that will, begin to amalgamate a lot of health data into cloud servers? So these are questions that I think countries are beginning to start looking at in terms of developing their own digital architectures. Architectures would also mean infrastructure, because the other big problem with this great digital debate is digital equity. And just as much as populations are increasingly exposed to digital tools, services, and technologies, there are as many populations who do not have access to them simply because there's not enough or sufficient digital infrastructure to support some of that where they live. So I think this is a balance, and I think it's really good that this has been brought to the surface of some of the larger consultations at the political level at the G20 summits.
Well, it also includes, sorry that I intervened, but just after what Priya said, it also brings some questions about intellectual property, no? And especially for those that have the means to have to make those platforms, and also possible waivers for countries in the low and middle income countries. No, I'm in Argentina, and in Argentina we haven't started too much. We are doing telemedicine here; it's being done, but not using the whole possibility of the digitalization. That is because that means that you have to have resources, and most hospitals and most physicians don't have them. No?
Yeah, thank you a lot for this great discussion on this very important topic. And now, because I'm also at GP as well, I would like to focus also a question to family doctors. What do you think? How can family doctors maintain also a holistic and human approach in the digital world? And maybe also Amanda Howe or which robots might also like to answer this question, but of course this is up to them, of course. So,
well, I think this is the question, isn't it? And thanks for raising it. So I don't have a solution. I have some reflections. I think the main way for us to try to retain person-centeredness or patient-centeredness is really to acknowledge that these solutions are not going to be an option for everyone. And people might not have the skills, they might not have the access, or they might have the skills and the access and still they might not want to use them. And I think that needs to be something that we have crystal clear in our minds. And one of the biggest risks that we see whenever we see digital health implementation programs is implementers actually neglecting these and just pushing a solution as this is the way, this is how we're going to do it, and not providing alternative routes. So from an implementation perspective, I think we need to be very clear that whenever we do this sort of rollouts, there needs to be an alternative route for those that don't want or are not able to use it, and they shouldn't basically get their access cut there. So that's a very specific point on access as well, but there's obviously a lot more implications as well in communication. So if we're thinking, for instance, about the new service delivery models, telephone, video, whatever it is, people might not feel as comfortable to have these sort of conversations remotely. Interestingly, it seems like in mental health, actually, patients that are able to engage with remote care actually feel that being remote in some cases can be a positive thing, can help them to open up a bit more, but that's not all the case. So to my main points from my side, first one, trying to understand that this cannot be pushed as a single route solution. This is never going to work. This is going to exclude people. And second point, trying to understand that communication barriers can be potentially enhanced by these solutions. And we need clear guidance on how to try to mitigate those risks. So this literally just scratching the surface. It's a much more complex topic, and thanks for bringing it.
Thanks a lot, Anna. I'm happy that Amanda was raising her hand. So please, Amanda, and then Gerry.
Yes, thank you for inviting me, Florian, and thank you, colleagues. Most of you will know me. I'm a retired family doctor in the UK and also very much involved with Wonka over the years. I actually put a comment into the chat that relates to this. So I think that's maybe why Florian invited me. So Anna, you said right at the beginning, one of those first of the 6 criteria was person-centeredness. And I think that clearly I am finding in our system, both as a patient as well as when I was still doing clinical work, that there were some good efficiency gains about access. You know, I could send a form to my practice describing a problem, saying when I could come or whatever, and then they would process it. And that seemed good. But they retained, and our system retained my care with that panel, with those doctors, with those nurses. And I could express a particular wish, you know, Dr. Jamie saw me last time and he said I should speak to him again if blah, blah, blah. And so I think the question about, you know, making sure that family doctors retain the humane and holistic approach is very much about retaining a place of registration, team who are known to you, a community that they work with over time, and incorporating the use of the digital technology, the self-monitoring, as Gerry was saying, whatever, into that system. Whereas in some places where people are saying, well, I send my form, but now I never get contact with the same nurse or the same doctor twice, or I don't see a human being, I don't seem to get that choice, even on video, let alone in person. That, I think, breaks down. And finally, my other comment, which I also was going to ask Priya, when you said about the multiple new providers, I mean, again, in my system, we have seen some of this. In fact, Anna and her research group are looking at some of these things about, you know, people registering separately with a provider who is not in their community, who doesn't have that same sort of care over time, care of the family model. But in India, as I understand it, that's sort of much easier, and the system may not manage that, or certainly what about the quality of those providers? So I think that the answer I would give for Florian is that the digital processes must sit within and be managed by a health system that prioritizes integrated and holistic person-centered care. Thank you.
I mean, I think I'd like to add a comment, and I mean, I'm living in the UK, and one can see some of the benefits and also some of the problems. But I think the danger for, and you're focusing on GPs, I think one shouldn't look at digital as an add-on to the old model of GP practice, because I'm not saying tomorrow, but I think it's important that GPs, and particularly as the younger GPs come along, that they start rethinking their role when they will have an integrated, I mean, one of the key ways forward with digital is you'll have an electronic patient's record with a lot more information. And so some of the integration will happen by having good information. But then the question is, what is the role of the, if we want to call it the GP, in what's going to emerge over the next 5 to 10 years? How might practices be structured to take advantage of the benefits and also to avoid, because there are clear risks, and we see it, that if people don't go on to the telemedicine or log on to the practice, they may simply be ignored. They may simply not be seen. So we have to see the problems and the opportunities and how that's going to require a restructuring of the idea of what a GP is and how a integrated practice can be organized. So and it's a message I'll bring after. I mean, we are now in a situation where we have a medical scene with a lot of ideas on how to organize healthcare, and we're trying to interact with IT companies or tech entrepreneurs, people who really don't understand our health sector at all. And I think we're going to have a struggle for both to understand what the new model of health system can be and how to manage it. And so I hope GPs are starting to look at what does this mean for practice in the next 10 to 15 years.
Thank you, Gerry. But if I can just add, it's a shame Kandan had to leave because she hosted or was the facilitator for this amazing OECD conference in Paris, where this was one of the discussions, and the ministerial summit, of which there are reports, was saying very clearly, and our government came out and very quickly made an announcement on this, that the whole provision, the algorithms, the AI, everything that's coming needs to be closely evaluated, but also managed into a system that remains person-centered. And I agree with you, it's a good challenge to say, so what's okay about changing your role and what's not? But I think we can all see that there are times in our lives where you do want to be looked after by some individuals who are walking through the problem with you. And that, you know, if the digital system allows multiple providers but no continuity, we're going to have lost what we gained. So anyway.
I'd like to just respond to your question, Amanda, and also to kind of expand a little bit on this GP debate. I'm a clinician myself, but I'm not a GP, I'm a dentist. And I have to say, as far as the dental community is concerned, they're extremely technologically advanced. We use technology in everything, from taking an impression to screening your mouth, to entertaining you when you sit back in your dental chair. It is one of the most technologically reliant professions there is today. There's a lot of technology involved everywhere. But when you come back to this question of the primary care provider or the GP, one of the challenges, at least in countries like India, and perhaps I can speak of other country settings in Africa and parts of Asia as well, is that this is a dying specialty. One of the challenges for India has been that there are not enough GPs in ratio to specialists. And what technology has started doing is to then facilitate the next level of provider, which are either frontline providers or nurse, to be able to empower them to do some of the work of a GP a little better, because they invariably become the first point of contact for many populations which do not have a GP access. You know, even in urban settings, it is hard to find a general practitioner. Most of the time when you are sick, the natural instinct is to go to a specialist. And that's how the care continuum eventually evolves. If you have money, if you don't have money, you would go to a government hospital, but nevertheless, you would end up seeing specialists. Unless, of course, you go to a primary care center, which is, I could be either urban or rural. And where urban centers are concerned, again, you know, the GP is often overworked, and sometimes uses or the use of technology to facilitate some of his work enables them to stay longer, to kind of offload some of their work to maybe nurses. And for the rural health practitioners, where invariably most of the rural health centers are not even populated by doctors, it is these frontline workers who are increasingly working with technology providers to see whether they can provide a modicum of quality or quantity of primary care to populations who may not simply have that ability to access it. Because invariably, they're either driven to the various vertical programs that deal with maternal and child health or others, or other areas, TB and so on and so forth, or NCDs. But to really create or access a holistic care model where, Amanda, you were talking about those communities of practice, which are so essential to keep care going, to keep that human touch. It is often technology that's beginning to empower some of these frontline workers who are taking on some of those roles and responsibilities when a GP is not present. So to me, it's a very interesting space. And, Gerry and I have worked with this interesting primary healthcare company called HealthX, which is based out of Kenya, which is attempting to fill some of these spaces, not only with frontline practitioners who use technology to facilitate some of the things that they do, but then to invariably link them up to GPs that are not always present in rural spaces. So just wanted to add to that.
Florian, could I jump in at this point?
Sure, I just wanted to ask you. Perfect.
Yes, well, and I apologize, I'm having camera issues, though that's probably, from your perspective, a good thing. Some very interesting and I think insightful comments that we've heard so far today. Let me begin by addressing the system issues. And our dental colleague from India, I think one of the things that I learned in the more than 5,000 doctor-patient encounters that I've observed now in more than 100 countries is that it's very easy for us to generalize about what primary care looks like, what family doctors do, and it's usually wrong. And the reason it's usually wrong is that there's a wide range from, family doctors doing major surgery out in the bush to very high-tech practices using laser, for example, for dermatologic issues. And so I think we need to be careful. One of the problems I've always had when people talk about primary care is they tend to slip into the pattern of thinking that it's a series of tasks that we do. That could be because that's how most specialists organize their work. Heart surgeons do heart surgery. Dentists do, teeth and gums. Well, the reality in primary care is it's only a little bit about tasks. It's much more about relationships, because the two parts to the human, health condition are the science, what we know and don't know, but it's also the person, and each one of them being unique. And that too often gets underemphasized. And I say that as a starting point, because I think what digital health technologies can do is they can ruin that, or they can support it. So as I started to travel quite a bit internationally, was still having a very busy practice back home in a somewhat rural community, I felt very guilty about that. And I'd always say to my patients, I've got great partners here. If you need help, they'll be sure to help you and let me know. But if you need me, don't hesitate to call me. And sometimes I get a call at 3 o'clock in the morning in Tashkent, Uzbekistan, and that was fine, but it was actually fairly infrequent. But using that and email, and even at times, when some of the video technologies began to come online, like Zoom, I could do consultations literally from all over the world. And it was really about extending the relationship, because I could take care of something in a minute that would take one of my partners, 30 minutes, that would take the emergency doctor 3 hours, and that would take the specialist all day. I mean, just because I knew the person. So that's for me, one of the greatest opportunities. The other opportunity is that the communication can be asynchronous. So in this case, talking about family doctors and patients can talk to each other at times that are convenient. Not everything has to be addressed right at this very moment. Also, I think that amount of information is really going to be at some level overwhelming fairly soon, as we begin to incorporate the biometric wearable electronics. And we're starting to see that. I've worked in an electronic health record environment for 35 years, and we've used 5 different systems, and the largest EHR company in the US is Epic, and they do some amazing things with plugins that you can now data uploads automatically on home blood glucose readings and sleep measurements and a whole series of things. And so you begin to use that for pattern analysis. I think the point that's been made by several of the speakers, though, which I very much agree with, that we need to remember, is that it's not just about the technology, it's about the systems, the investment, making sure that it's equitable, that it reaches all the people that it needs to. We found, for example, as electronic health records roll out across the US, that primary care doctors began to talk about pajama time because we were spending 4 to 5 hours every night just working through the electronic health record stuff that we didn't have time to do during the day. Well, that's not sustainable. And yet there are emerging solutions, artificial intelligence prime among them. You know, Kaiser, the health system, just released a study that showed that they were able to reduce by half the amount of outside of clinic time people were spending on the electronic health record. So I think the opportunities in digitalization are fantastic, but the harms are concerning. I mean, when you look at AI as a way of, for example, diagnosing problems, it gets it wrong more than it gets it right, and that's going to be the case for quite some time. And especially in primary care, because what we do in primary care is frankly more complex than what specialists do. If you take the average cardiologist, he or she will see about 90 to 95% of 5 ICD-10 diagnostic codes, and that's it. If you look at the average family doctor and you take just the top 2/3, that's 25 diagnoses just for the top 2/3 of what we see. So what we see is a much broader and more complex range of human ailments, and the database that we rely on, the knowledge base, is really wanting, and that's a huge problem. It's, garbage in means garbage out. So I think if we're mindful about these things, the equity issues, security issues, interconnectivity, all those things that'll make the system work optimally, and we hold ourselves and our systems accountable to that, there's a great future in this. But there are going to be a lot of trips and stumbles along the way.
Those are great points, Richard. I totally agree with you. And in fact, just to kind of continue this conversation, Gerry and I have often been up against technologists who are not necessarily from the medical field, but they are engineers, biomedical engineers, who often work on a very a bidirectional problem and solution space. You have a problem, we have a solution. You have a gap, we can fill it. And they kind of approach health also as a problem that needs to be solved. And in many ways, even as they are designing their solutions, they sometimes fail to understand the messiness and inherent complexities of health systems. That it's not a linear, kind of top-down approach, but it is a bottom-up approach, and where primary care is often the base of a movement in the life cycle of a person as he moves from young to middle age to elder care, and all the complexities that happen in between. And this is often a challenge, and it will be a challenge as this debate between physicians and health systems folks and technologists become more intertwined. And this is something that needs to be addressed. And part of the work that a lot of health systems researchers are also doing is to say, how do we bring this argument to technology folks while they are in the process of design? Because at the end of the day, this health is not a singular problem to be solved, as many of you have so articulated so well. It is really a multiplicity of inherent causes and effects that need to be addressed in the course of somebody's lifetime. So it's a challenge, but I think this is something that worries me a little bit, particularly as digital occupies a wider space in how health systems are going to be operating.
So, real quick response to that, because I think it's an excellent point. There is good news there. For example, at my institution, the University of Wisconsin, we've had one of the preeminent engineering departments, industrial engineering, and typically industrial engineering is looked at workplaces and how to make the factory safer. But in our university, one of their areas of excellence has actually been in health for 45 or 50 years. And they really do begin to get it when they've spent time in our primary care settings. In fact, one of the industrial engineers explained to me, he said the problem that you have in primary care in terms of helping others help you, in consulting engineers that might come in and try to help with your digital health system, is that you're being squeezed into what we call a linear manufacturing model, like an assembly line. You hand the patient off in a series of handoffs down the system. But he said what you really are in primary care is you're a complex adaptive system that has to customize a solution for each and every patient through the entire life cycle, from before they're born, when you're doing preconception counseling with a couple, after they've been dead and you're meeting with the family to talk about grief and working through the loss of a loved one, and everything in between. And most people, even in healthcare, don't get that. And I think in primary care, it actually takes us a while to figure that out, even though we've been well trained. You get out there and you start doing it, and then you begin to see the power of those relationships, of those connections, of being able to look across not only the person's life cycle, but the family, and in turn the community. And it really is a much more holistic way of looking after people, which is why systems built on family doctors get the best results with the best equity at the lowest cost. It's that simple. So one of the things that I think will cause countries at times to be tempted to slide toward building the system on specialism is that they'll find that it gets so expensive and the results become much less desirable than when they had a better, more robust primary care, and they'll start to reinvest. And we're just starting to see that right now in the US, because we only spend about 5 to 6% of the health budget on primary care, where many of the OECD countries, it's double that. And state governments, and I don't live in a country that tends to historically be very supportive of any kind of health or social services, but state governments are standing up and saying, wait a minute, we've got to change this because it's just not working for our population. So I'm cautiously optimistic that, as Churchill used to say, we'll do the right thing after first exhausting all the alternatives.
I have one last really important question at the end. Why are some of these solutions not already implemented? Why were some of them not already implemented 10 years ago or 20 years ago? Why is the healthcare sector sometimes lagging behind on this topic?
I can have a start. I can start. So I think the main thing is that implementation, to be successful, needs to start much before we actually deliver the solution. So, and one of the things that sometimes doesn't go really well is that people develop a solution, a digital solution, in a bit of a bubble. It's a bit of an echo chamber. We think there's a need, we develop something, and then we try to push it back to the system. And what we have seen in the last decades is that that doesn't work. So whenever we start to think about developing some sort of digital intervention, this needs to be socialized at a very early stage with key stakeholders. This needs to be discussed with the people actually delivering care. This has to be discussed with patients, and this has to be co-designed so that they feel part of the process. And then once we finally reach out to stage of implementation, they can see the value, they can see that this is going to make their lives better, easier, or improve delivery of care somehow. So for me, I think that's the first part. So implementation starts very early in the process. It's not just when you have the solution finalized, really. And that's complex, that's messy, that's going to involve a lot of different voices, but that's the only way that we can really make this work. So for me, that's one point about implementation, co-design, and early involvement of stakeholders. And I have just a reflection on a specific, going back to your point, Florian, on why didn't healthcare pick up on digital innovation, and particularly on healthcare data use as early as other industries. I think fundamentally healthcare, we cannot afford to fail, right? If you use healthcare data in other contexts, and this can be debatable, really, because we use healthcare data for financial purposes, and people feel, relatively comfortable sharing that information with banks and all of that. But if you ask people, users, how comfortable do they feel about their healthcare data being shared, for instance, for research purpose or public health purposes, people feel in general a little bit more cautious than they feel when they tick terms and conditions, yes, whenever downloading an app. So I think that's an important consideration for us to keep in mind. And this is a specific point about healthcare data. So it's not about digital innovation, but every time we talk about healthcare data sharing for greater good purposes, for public health purposes, we must be very mindful that the public's perspective and the public's openness to share this sort of data is very different than it has been in other industries. So I'm talking about marketing, which I've been using consumers' data for decades without any kind of major concerns from the public. So yeah, these would be my two major points. So the public's perspective, it's very specific. It's very different in healthcare than it is with other areas. And implementation needs to start from the beginning. It's not just the final step of the process.
I mean, first, Florian, when you introduced me, you said I'm at the Institute of Development Studies, but I should say that with Priya, we are co-facilitating what we're calling the platform for mutual learning for mixed health systems. And I think the reason I'm raising it is the mixed, we mean mixed public and private. And so I want to make a couple points there. But the first point I want to make is I started the first thing I said in this discussion was a kind of vision of this digitally enabled health system, and it looks beautiful. But I can give you a dystopian vision of it. You know, a health system where there is greater inequalities between an excellent digitally enabled system and very basic services for those who can't get online, who can't afford it. We might have an expensive style of care because drug companies and particularly diagnostic companies might be linking up with digital platforms to promote an expensive style of care. We would have use of data to develop treatment algorithms that meet commercial needs and actually maybe a loss in trust rather than a gain in trust. And I guess what I'm saying is that would be a health system that resembles other markets. Commercial, driven by commercial needs, advertising, trying to find clients, or as they talk on the social media, clicks, and all that is possible. And I mean, and Luisa's absolutely right. In health, we have, I mean, there's political reasons as well as moral reasons why governments are very cautious about changes that might cause harm or might lead to crises. So we're in a conservative sector, and maybe that's a good thing. But the fact that there is a dystopia that could happen, it's probably not going to happen. Then we have to think, well, what are the other issues that need to be solved in order to have a managed transition? And I put a couple things. One reason, I mean, and I'm more interested in low and middle income countries and universal health coverage. There have been a very large number of proof of concept pilots all over the place. Almost none have gone to scale. I mean, one reason they haven't gone to scale is this was a very immature technology. All it did is gave information to patients, might give them advice. But people don't just want information and advice, they also want treatment. So it had to be linked up to getting access to drugs. And if you're just going to get advice, but you haven't put in any information on your health status, it's not very useful. So we also needed low-cost digital, low-cost diagnostic capacity. So, but now we're moving towards that. So, we've had a period where we really had a very immature technology. Things weren't really integrated, and not surprisingly, they didn't give a lot of benefit. But now it's possible, but there is a big challenge. And I guess that's what I wanted to emphasize. Many health systems and many primary healthcare systems are a combination of government and some kind of private. In the UK system, actually, GPs are private, but they're on full-time agreement and contract with the government system. And in many other countries, there's a public and a private system. And I've been involved with WHO. It's actually very difficult for governments to figure out how to manage the relationship with the public and private sector, how to ensure that the private sector is actually contributing to universal health coverage and to an affordable, safe, and effective system. But now it's much worse because we're talking about a private sector that's essentially information technology companies. There's some very big ones that are coming in, and we all know who they are. They're American, but they're also Chinese and they're Indian. And almost every country has a large number of small technology entrepreneurs. And I'm thinking of the intervention from Argentina. Although Argentina isn't moving, I'm absolutely confident that Argentina has large numbers of tech entrepreneurs who are developing all sorts of ideas and solutions. So what is the Argentinian government going to do? Is it going to sign a contract with a large multinational information technology company? Is it going to make agreements with Argentinian companies who can help the system operate better? But then the public sector is very used to signing contracts that are very well specified. But what if we want companies that are able to that innovate? How are government going to agree with technology companies to allow them to innovate, but make sure they're accountable for what they're doing and that they're actually contributing to universal health coverage? How can the tech companies, as Priya said, learn how to design their interventions so that it's beneficial for the public health system? So there's a lot of learning on both sides that has to happen. And that leads me to the last thing. Right now, we have a whole series of regulations to protect the safety of the public that have been quite conservative in terms of digital interventions or advertising or many things that are potentially harmful. How are the regulatory arrangements going to adapt to both allow innovation and progress with digital transformation, but protect against the privacy of data, to protect people against damaging information? We have had, during COVID, we had a lot of problems with disinformation. So how are we going to make sure the information is good quality? How are we going to make sure that as companies collect data, that it's used for the public good? There's a whole series of issues to solve in order to ensure that we can really benefit from the digital transformations that are coming, for sure, but that we avoid some of the worst pitfalls. And I think we should see ourselves now in a period of learning and experimentation. And I think the key thing is to have an open mind and to ensure that any intervention we build in learning and learn over time how to do this well.
I think, Gerry, you've said a lot of things that I completely agree with, and it's, I really don't have that too much to add to what the two of you have said. I guess, to me, I think these solutions, many of them are already being implemented. It really differs from one country context to another as to how, where, and at what scale. In India alone, I mean, there is something called the Geo eMitra Primary Healthcare Clinic. There's iCure TechSoft that provides integrated primary healthcare. There's Neurosynaptica that's providing integrated primary care and teleontology. All of them work in different states. All of them work in fairly narrow spheres. Some of them work in partnerships with states. Some of them work as independent care providers. So, going back to what Gerry was saying, I think at the end of the day, the implementation is already happening. What's really not happening is the integration and the kind of regulatory framework or architecture that's needed to address some of these smaller providers and how they would interact with public health systems in a good way that allows them to be contracted in or be part of this public healthcare delivery network. And the second is, of course, the larger companies, which include, the giants, whether it's Google or Amazon, who are increasingly venturing into the healthcare space through personal wearable devices, through the integration of AI into every platform that actually listens to and follows the choices that you make. And all this can actually impact, and as Gerry says, adversely impact how care is provided and maybe create even deeper divides in terms of equity and equality when it comes to services. So to me, the future is a balancing act, and it's a balancing act in progress because you cannot ignore technology. It will be there. It will disrupt and find its way to whatever you do, because that in many ways is the future. AI has already, infiltrated into almost everything we do. If I talk at length and my phone is lying there, when I scroll down my next YouTube or Instagram feed, it will say primary health, et cetera, et cetera, et cetera. But that's technology for you. It's insidious. The question is, how do we have more cogent conversations around harnessing this technology in the way we want it, not the other way around? And I think that is the most important thing. And that's the thing on which these larger questions around legal frameworks, regulatory frameworks, and integration really hinge.
Thank you a lot. I think these were really, really great last words of our official part of this panel discussion. And in this way, I would really like to thank the panelists again